So I think that we'll go ahead and present our next speaker. Many of you will probably remember Dr. Mary Naughton from this morning, and she will talk about immunizations and the I-693 form.
I hope you enjoyed your lunch. And vaccines are usually a topic of great interest. There's usually a lot of questions, so hopefully we'll address your questions as we're going along here. And if not, we can hopefully have time for some questions after or during the time of the talk or after we finish up today. So we're going to be talking about vaccination requirements for the civil surgeon exam and Form I-693. And what I'll be speaking about is the legal requirement for immigrant vaccination, the process to determine which vaccines each applicant must show proof of having received, so-called recent changes, and the influenza changes as far as which type of vaccines are available is a few years old. Pneumococcal vaccination for applicants 65 years and older has become more complex, and that first was included in the ACIP schedules in 2015 and actually has become a little bit easier in 2016. We'll talk about special populations like refugees and K-visa applicants, and then again give you the references and contact information. And hopefully you'll know the algorithm to go through for selecting and ordering age-appropriate vaccines, and hopefully you already know this, but it'll just be a review for you. For adjustment of status applicants, recall basic knowledge about the 3 types of influenza vaccine, and demonstrate basic familiarity with the new pneumococcal vaccine requirements for applicants 65 and older, and explain how refugees and K-visa holders differ from other applicants presenting for adjustment of status. So for vaccine requirements for U.S. immigration, in 1996, the U.S. Congress amended the Immigration and Nationality Act, which is otherwise known as the INA, by adding to the health-related grounds of inadmissibility proof of vaccination requirements for immigrants. So this means that the immigrant must show proof of vaccination or have a good reason that's documented for why they are not able to show proof of vaccination for the age-appropriate vaccines. And so any person, as I was just saying, must show proof of having received vaccination against vaccine-preventable diseases, and these are as recommended by the Advisory Committee for Immunization Practices. So this is ACIP. And ACIP, they make recommendations for the U.S. public, for people who live in the U.S. And those vaccinations are required for people who are being examined overseas and are immigrants or people who are adjusting status in the U.S. because that's the equivalent of being, adjusting status is more or less equivalent to applying as an immigrant when you're overseas. So according to the INA, this is before December 2009, immigrants were required to show proof of having received all vaccinations that the ACIP recommended for persons living in the United States. And then in 2009, some changes were made. And what we changed to is that the vaccine must be an age-appropriate vaccine recommended by ACIP for the general U.S. population, and for vaccines not named in the Immigration and Nationality Act, because some are actually named. So measles, mumps, and rubella are named. Diphtheria, tetanus, and pertussis are named. But for those that aren't named in the INA, they must have at least or meet one of these following criteria. The vaccine must protect against a disease that has the potential to cause an outbreak, or must protect against a disease that has been eliminated in the U.S. or is in the process of elimination in the U.S. Or if the vaccine meets both criteria, then of course that counts also, but they must meet at least one. And so required age-appropriate vaccines. We know diphtheria, tetanus, pertussis, named in the INA. Polio is named in the INA. Measles, mumps, rubella, named in the INA. Now, we didn't have a rotavirus vaccine in 1996. It wasn't named when the amendment was made to the INA. Haemophilus influenza type B, we consider that as named in the INA. What the INA said was influenza type B. It wasn't quite clear whether they were talking about Haemophilus or talking about influenza. So we consider both of those as required. Hep A is required now. Hep B was named. Meningococcal is required, varicella, pneumococcal, influenza. And you'll notice the list does not include herpes zoster or human papillomavirus vaccine. And some of you may remember that for a few years those were required. But they actually give more protection to the individual rather than to the population. And there can be some dispute about that as far as the HPV vaccine. But currently they're not required for persons who are adjusting status. So, and again, now we get into the classification of vaccines. Which ones are live and attenuated versus inactivated vaccines? And so why is this important to know the difference between the live ones and the inactivated ones? Yeah, the main reason is pregnancy, that you would not give live vaccines during pregnancy. So the live attenuated ones are measles, mumps, rubella, oral polio, which we no longer give in the U.S., rotavirus, varicella, and intranasal influenza. The other influenza vaccines are inactivated. So on the inactivated list, we have DPT, we have the IPV polio, so the injectable polio, Haemophilus, Hep A, Hep B, meningococcal, pneumococcal, and the other influenza, so the injectable influenzas. Okay, and now the components of vaccination evaluation. First of all, and this is something that's important for the whole exam, and I was explaining earlier, this is why you can't accept outside chest x-rays, that you have to order a chest x-ray if one is indicated, and that's because you have to, as a civil surgeon, one of your responsibilities is to ensure that the person who you are examining, and that includes the person on whom the chest x-ray is performed, the blood is drawn, that's the same person as the one who's applying for the benefit. And so that means the same person who's applying for adjustment of status. And, you know, in the regular hospital, you know, somebody's going to check your arm ID to see if you're the right person to get the chest x-ray done, or they should do that. But they may not be looking at a picture to make sure that you're the appropriate person. And it's just not the same level of scrutiny that should be done, whether it's in your office or if you send to another facility to get x-rays done or to get blood drawn. They should be making sure this is absolutely the same person. And my experience is more overseas, but we've definitely seen cases, and this used to happen more when there was HIV as a requirement, where people would substitute others to have the blood drawn. We do see it with chest x-ray sometimes, where people feel they have, or they know they have an abnormal chest x-ray. They think that is going to disqualify them, and so they send somebody else in to get the chest x-ray done. So you're responsible for making sure that it's the person who's applying for the benefits. So it's important to verify the identity, and also then review previous vaccination records if they're available. Self-reported vaccine doses are not acceptable, just like self-reported TST results aren't available. And the only time you accept something about TST is when they say that they had a blistering reaction. And so we say check evidence, or check records for evidence of fraud. And I'd have to ask my colleagues at USCIS exactly how they feel about this. I know that our point of view is if the physician is looking at a record and they think it's fraudulent, they may know that in a certain other country the vaccine that's written as being administered was not available at that time in that country. It may be, sometimes it's a very clean record with the signatures all the same, the handwriting's all the same, the color ink is all the same, and then that can raise your suspicion that this actually is not an accurate record, that it is fraudulent. We say it's up to you to make that determination. And do you have any comment on that, Bruce or Rosalind?
If you feel that something is not quite right, you do have the option to just attach it, make a copy, attach it to the I-693, maybe have a comment. That will be also appropriate.
So then do you want the panel or the civil surgeon to go ahead and give the vaccine that they think really wasn't given previously?
It really is a medical, judgment what you feel was available or not. We wouldn't have the way to check it.
Okay. All right. Good. Good. So you can use your clinical judgment. Go ahead. If you think a vaccine needs to be repeated, go ahead and tell the applicant that. And then the other part, and this is a big part, and it's become bigger over the past 5 years. It's just vaccinations get more and more complicated. And it's an unfortunate fact of life, and it's probably, as the experts learn more, it just makes it more complicated for everybody. And of course, as we have more vaccines, we're doing better in preventing disease, but it does make your job somewhat harder. So the first thing is, which are the age-appropriate vaccines, and of course the contraindications and the precautions. So this is the process we say to go through. Of course, determine the age, review the medical history and the vaccination records, and then look at the vaccination table that we have in the technical instructions. And we update that table when there are changes to it. So if you printed out the vaccination technical instructions in 2009, that's a different table than what's in, than what is online now in the technical instructions. So we haven't updated the text part of it, but the table changes. And our last change was within the last year. So review that table to determine the vaccines for, that are required for this particular applicant for their age. Then go to the ACIP schedule, and I'll show you slides of both of these. And you have to read the footnotes is what it comes down to. The schedule just gives you the basic information, and then you have to go to the footnotes for that vaccine. And again, that'll tell you more about contraindications, precautions, and catch-up doses. And then you can also assess laboratory needs. If the person says, I had that disease and I really don't want to get a vaccine, then you can, it's listed in the technical instructions which diseases the lab tests are acceptable for to show immunity. We don't actually require that at this point for varicella, which is different than ACIP, but that's something we have to change. We have to catch up on our technical instructions. But it'll tell you you can do that for measles, you can do that for mumps, you can do that for rubella, and there are other conditions. So this is what the table looks like in the technical instructions. And you can see the ages at the top, vaccines here, and then this is the breakdown of ages. And it tells you yes, and we try to be very exact here. We stopped using dashes. It's through a particular age or up to a particular age. And for things that are more complicated, like the pneumococcal, we just say here, administer either PCV, so the pneumococcal conjugated vaccine, or the pneumococcal polysaccharide vaccine, depending on the vaccination history, and we'll go into that a bit more. You can see for influenza, it's everybody 6 months and older is required to get an influenza vaccine during flu season, and that is unless there is a contraindication. So again, this table is adapted from the ACIP recommendations and must be used in conjunction with the current ACIP schedules. You know, in before 2009, or it might have been before 2007, we actually tried to say everything about each vaccine in our technical instructions. But things change 3 or 4 times a year because that's how often ACIP meets. So it's actually the most accurate source is going to what the schedules say. And so you can find these online. And this is the schedule for age 0 through 18 years, and this is for 2016. This changes every year. These come out the first week in February, and so that's when it changes online. Now, they'll make some other changes, ACIP will, during the year, and we don't actually hold you to that. We figure if you go in on the beginning of February and you know what it says at that point, that's what we hold you to for that entire year. You can see that it lists the vaccines over here, and then we have yellow boxes, we've got green boxes, we've got some purple boxes, and it tells you down here, this is your key. So this is the range of recommended ages. It says for all children. So, and this is basically, this is when they should be getting the vaccines, and it gives you some ideas to which dose. This is for catch-up. The green is for catch-up. The purple here is for certain high-risk groups. And it was decided back in the 90s that you weren't required to give the vaccine to an applicant who's adjusting status if the only indication is that they belong to a certain high-risk group. Because we were trying to have an even playing field, and it's a good idea to recommend that somebody receive a certain vaccine if, say, if they've had their spleen removed or there's some other indication. But you're not required to do that, and part of the reason is because the immigrant applicant is paying for these vaccines, and we were trying to keep the playing ground level, so that some people weren't paying for multiple other vaccines that other applicants weren't paying for. So, and then we really don't need to worry about the blue here, and then if it's blank, it's no recommendation. But what you'll see, I reviewed this here, so yellow, it's the range of recommended ages for all persons. This is the catch-up. Again, the purple is for certain high-risk groups, blue we won't worry about, and white is no recommendation. So which colored bars on the ACIP schedule must the civil surgeon use when assessing the vaccination needs for adjustment of status applicants? So it's the yellow and the green, exactly. And so that at least breaks it down and makes it a little bit easier for you. So on the ACIP schedule, you find the age range, so that's the column, and then for each row, you identify which vaccines for that particular age have a yellow bar or have a green bar. So, or which cell is green, which cell is yellow. And then you continue the process to determine if these vaccines should be administered. And if you happen to see a purple bar there, again, it means administer only if the applicant's high risk. You don't need to do that, but please do advise them that they would need a vaccine if they haven't already received it. Okay, and so here we are again, and what I was trying to show you over here is that these are footnoted. so that when you go to the, you're up here, you know that you should go to actually footnote number 7. This is the 7th vaccine, and so it's footnote number 7. So if you're trying to figure out what you're going to do about influenza for someone, then you look at the footnote number, and you go down to the footnotes. And at first, they just look absolutely overwhelming because there's just so much print there. And hopefully you're going to be looking this up just for a few vaccines, not for 5 or 6 of them. But this really does give you the information that you need. And so here we go to footnote number 7. And so this is about influenza. And here we blew up what that box says. And so it does say, minimum age 6 months. And it does give you the different ages for the different types of vaccine. It's 2 years if you're doing the live attenuated influenza vaccine, the intranasal. But it's 6 months for the injection, for what's called the IIV. And so it's going to give you all these details about which you can give. And as it says, for most healthy non-pregnant persons aged 2 through 49 years, you can use the LAIV or the injectable. LAIV should not be administered to some persons. So it goes, again, with severe allergic reactions, but it talks about also people who just shouldn't receive live vaccines. And, of course, when we're talking about influenza, we get into egg allergy. And it used to be that if you had an egg allergy, you couldn't get an influenza vaccine. But that has changed. And let's see if we have it here. I think we talk about it a little bit later in more detail. So how many of you have practices where you're just seeing applicants for adjustment or doing examinations for, pilots or that sort of thing? How many of you have practices where you're just doing that? Okay, so how many of you do you have your own caseload of patients who you know? Okay, so you're used to giving immunizations then, and hopefully you're going through this process when you're giving them. And of course, you have to look at them with your private practice hat on, is what we would say, as opposed to your civil surgeon hat. You would be looking at, do they have any high risk, or do they fall into a high risk category? You would want to vaccinate them. But again, that isn't required for the applicant who's there for the civil surgeon exam. Just let them know what they need. So that's an example. And then on the pediatric schedule, and then we have the adult immunization schedule, which takes care of 19 years and up. And again, we have we're looking at the yellow boxes. We're out of catch-up vaccines by 19 years of age. So we're just looking at yellow and at the purple. And so here's an example here, the tetanus, diphtheria, and pertussis or acellular pertussis. And how many of you see people coming back for repeat exams? You have to redo the whole thing because the first exam timed out. No, so that happens a fair amount. So say you have somebody who was overseas who never, they're now 25 years old, they never got any sort of DTP, whatever, as a child or later in life. So for that first exam, when you see them, what would you want to give them? What type of diphtheria? Exactly. You'd want to give them Tdap. Now, when they come back to you a year later, because their exam has expired for whatever reason, so it's 15 months later, 18 months, what are you going to give them? Well, see, it's generally thought that you would give them nothing, and I think that's because we used to not go into quite as much detail about this, but if you read the footnotes, and this is the only way we can figure how to do this in a consistent way. So if you read the footnotes, it actually does say, that for persons who haven't received a full course of the immunization, so they haven't gotten all of the injections, or people who had, have just well, at that point, they wouldn't have received a full course because you would have given them the Tdap, then you actually would give them further vaccine when they come back and see you. So, because it's not just like somebody who was fully vaccinated when they were a child, you give them the Tdap and then you don't give them anything else for another 10 years. So it's different because they don't have that baseline of childhood vaccination. So this is just showing how the footnotes are helpful in that respect. This I'm showing you mostly because this is a table that shows you when certain vaccines are contraindicated, and as you can see, here's the live vaccines. So varicella, zoster doesn't apply to us, but the measles, mumps, and rubella, that they're contraindicated when someone is pregnant, or we say, for our purposes, when someone is known to be immunosuppressed. And this is an app. I don't know how many of you take advantage of this so that you can just easily look up on an app the vaccines that are required. Want to go back to that app? Okay. Okay, and so this tells you, you know, these are just basic contraindications. So any vaccine, severe allergic reaction, live attenuated, and here we are talking about, again, the MMR, the varicella, the live intranasal influenza vaccine, pregnancy, and severely immunocompromised conditions. And for the MMR, what is said is that one should avoid becoming pregnant for 4 weeks after vaccination. And so that's something you should instruct the applicant. And pertussis, if there was encephalopathy within 7 days of a previous pertussis vaccination. So these are true contraindications. These are not contraindications. So mild to moderate local reactions to a previous dose of vaccine. And this usually happens with the inactivated vaccines, not the live ones. But that's not a contraindication. And, you know, I've received many, many vaccines because I travel overseas, so it's not unusual for me to get a local reaction. But that doesn't mean next time around, once that's expired, that I don't need to go back and get that vaccine again. Mild acute illness isn't a contraindication. Severe acute illness is. Recovering from illness, you can go ahead and give the vaccine. Antimicrobial therapy, you can. Now, tuberculin skin test, you can give all vaccines on the same day as the TST or any time after the TST is applied. But what's important to know is that if live vaccines were given before the TST, you have to wait 4 weeks until you give the TST. So this actually would have been more appropriate to say this morning. But when you have people coming in, and of course they need to get a TST or an IGRA done, if they have gone to their own physician and gotten vaccinated before seeing you, and it was a live vaccine, they have to come back. You can't get an accurate TST because their response is going to be suppressed by having gotten those live vaccines. And we don't have as much evidence about IGRAs. I don't know if you want to speak up, anyone at the back. What I understand is that since we don't have as much knowledge about the IGRAs, the same rule applies. That you do it by? Yes, you can do it at the same time, but if they've gotten the live vaccine, you have to wait 4 weeks for the IGRA or wait 4 weeks to do the TST. Yeah. So, okay, and here's some not contraindications. If sometimes this comes up, if there's somebody who's pregnant or immunosuppressed in the household, can you give them? And you generally can give them. Breastfeedings, for the vaccines that are required for the civil surgeon exam, if the applicant is breastfeeding, you can give all of the vaccines that are required. Preterm birth, this probably is not going to be coming up for you because by the time you would see the child, they would be older, but that's not a contraindication. Family history of adverse events is not. One thing we do say is for healthcare workers who care for severely immunocompromised persons who are actually isolated because of their immunocompromise, that they shouldn't receive live attenuated vaccine. Or if they do, they should refrain from the care of that immunocompromised person for 7 days. Now, I wouldn't expect that this would come up often on your exams. If that is something you come up against, email us at the cdcqap@cdc.gov if you have further questions about it. So precautions, and if there is a precaution and you feel that it does mean that you shouldn't give the vaccine, and it doesn't always mean you have to come to that decision, but if you decide that, you can mark down that there's a contraindication to giving the vaccine. That's what you can put on the Form I-693. So moderate to severe acute illness is a precaution. And for TD, Tdap, meningococcal, and influenza vaccines, prior Guillain-Barré syndrome is, even though we haven't seen evidence of that since 1976. So rotavirus, you know, we had those problems with intussusception back in the late 90s when those vaccines first came out. But those were rhesus-based vaccines, and the ones that are on the market in the U.S. are no longer rhesus-based. So you really don't need to worry about that. But again, if you have a question about that, you could email us and ask what to do if there's a history of intussusception. For the DTP and DTaP, if there was a fever of 40.5 or greater, within 48 hours, persistent crying for greater than 3 hours, and convulsions with or without fever within 3 days. And again, if it's not administered due to a precaution, mark contraindication, and I'm sorry, I put DS-3025, but it would be Form I-693. So after vaccination, of course, you can see the pain, swelling, and redness at the injection site, especially with the inactivated. That's usually mild and self-limited. You can get systemic reactions, and that may or may not be related to the vaccine, and these may also just be, should just be limited in time. So spacing of live vaccines, and this comes up if somebody's received a live vaccine shortly before you see them. They must be spaced apart by at least 4 weeks. So these are just the live vaccines. And so if they've recently been vaccinated before seeing you, and this is with any live injectable vaccine or with the intranasal live vaccine, if the interval is less than 4 weeks, what you can mark on the form is just insufficient time interval. Mark that on Form I-693. It's one of the columns to the right, and I'll show you that. So we're not talking about oral typhoid. We're just talking about injectable live vaccines and the intranasal influenza vaccine. And the other time you would mark insufficient time interval on the form is if the vaccine series is not completed at the time of the civil surgeon exam. And that's going to come up if you have somebody who didn't receive any of that vaccine previously. And so you're giving them 1 dose, because 1 dose is all that's required when there's a series of vaccine, or a series in that particular vaccine. So, and that's because we didn't want people to, be waiting months or a year or so on completing a vaccine series before they could be cleared by you to get their green card. But you could also then mark insufficient time interval if the vaccine isn't completed. I'm sorry, I didn't. You wait. The reason that you wait to, if there's been live vaccines, the question was, why do you wait 4 weeks? And so it's 4 weeks after live vaccines, and that's because you would get a false negative skin test, or could get a false negative skin test. I don't know if it's because most of your immune response is concentrating on the live vaccines that you have received. But, and I'll tell you, I'm definitely not a vaccine expert. I'm the person who can tell you what to do and not do as far as the civil surgeon exam goes, and so we've learned quite a bit about vaccines. But whenever you have a question, you can email us, and then we have our contacts in the immunization areas at CDC, and we ask them. Yeah. So, but that's what's been showed, that there's a depressed response. So these are the practical issues. As we were saying, only one dose of each vaccine series is required for the adjustment of status exam. You need to tell the person that they need to finish that series, but only one dose is required. And it's okay to give multiple simultaneous vaccines. Now, in years past, there had been a limitation. You know, you can't give more than such and such number. But there's no maximum number of vaccines per visit. Just use separate body sites and don't mix the same vaccine or mix in the same syringe unless those vaccines are licensed to be mixed together. So you would just give them in separate syringes. On the form I-693, every row should have at least one check mark to say, yes, you administered it, no, you couldn't because there was a contraindication, and we'll go over the different columns and rows, but every row should have at least one check mark. And you shouldn't sign until after the vaccines are administered because actually you don't know which ones are administered until they're actually completed. Now, this is something that because of the way the law was written back in the mid-90s, almost every applicant is going to require a blanket waiver. And this doesn't quite make sense, but this is just the way it falls out. So, and we'll go into that a little bit more. So, again, it says for the vaccination technical instructions and the updates for civil surgeons, they require immigrant applicants of which age group or groups to show proof of having received influenza vaccine. So 6 months to 18 years, 50 and older, so E, yes, 6 months and older. And those of you who have been doing this for a while know that this almost changed yearly for a while. You know, that we had it split for a while, that if you were younger and if you were older, you needed it, but it's been this way for about 5 years now. So it's easier to remember, it's 6 months and older. And as we, you know, as we try to remind people, it's, you know, it varies from year to year, but 30,000 to 40,000 people die each year in the U.S. of complications of influenza. And with most types of flu, that's the very young and the very old, not with all types of flu, but that's why the immunization is so strongly recommended, and that's why it's required for people who are adjusting status. We don't think about that very much, but when you compare those numbers to some other conditions, it's so much higher. And this is something we can't fully prevent, of course, because it doesn't address all strains. Some years it isn't quite right in its preparation. It's very tricky to get it completely, or to try to get it as correct as possible. But I know for myself, I certainly get vaccinated every year. So, and can influenza vaccine be given to persons with an egg allergy? It can be, yes. So, but it depends on the type. So the two types that you can give if the person has an egg allergy is if it's a hives-only allergy. So that's all that happened. You can give them the inactivated influenza vaccine. Now, you can always give recombinant influenza vaccine, the RIV, even if they had a more severe reaction, because this is recombinant, it's not made with eggs. You know, you don't have that as a substrate. So they can receive the RIV. Now, of course, they have to be in the right age group to receive the RIV. So we're talking, as I believe it's, you know, here we go, 18 through 49 years can receive the RIV. And so if the person's 6 months of age or older, and this includes pregnant women, and then the person's with a hives-only allergy, they can receive the inactivated influenza vaccine. So you have those two basic rules, but you then need to look at the preparations themselves to see which are appropriate for which age. So, and I know this might be a little much at this time of day, but this is a bit of matching to do. So which one of these, so we've got for A, we've got inactivated influenza vaccine. So that's the old type of influenza vaccine we all think about that's injectable. B is the live attenuated influenza vaccine, which is the intranasal. Then C is the recombinant. So which one does not contain egg? Exactly, it's C. So which is appropriate for persons, I said here persons 2 through 49. Yeah, but it's actually 18 through 49. Yeah, sorry about that. But yes, the recombinant. So appropriate for persons 6 months of age and older. A, yes. Should not be administered to persons under 18. C, yeah. And should not be administered if a child 2 through 17 is taking aspirin or an aspirin-containing product. So it's B. And actually what I should have said for the second one, that's 2 through 49, that's B. That's the live attenuated influenza. That's the intranasal. So that's 2 through 49, and then the RIV is the 18 through 49. The thing about the live vaccine, the intranasal vaccine, is there are a number of contraindications and precautions to look at. So that shouldn't be administered if the child is taking aspirin or an aspirin-containing product. And how about should not be administered if there's a history of asthma or wheezing in a child 2 through 4 years of age? B, yeah, exactly. Yeah. So it is more complicated to give influenza vaccine nowadays, but at least we have all of these different options. So people who have egg allergies, people who would prefer intranasal, we can do that. But again, this goes back to read the footnotes and read all of the footnotes, even though this can be daunting. But the basics are that IIV, or the inactivated influenza vaccine, is injectable, is appropriate for 6 months and older. The intranasal, or the LAIV, is appropriate for healthy, non-pregnant, and they have to be non-pregnant because it's a live vaccine, 2 through 49 years of age. But again, there are multiple contraindications and precautions. Recombinant is injectable, but this is actually 18 through 49 years and no egg protein. So pneumococcal vaccines. So this has gotten much more complicated because it used to just be somebody 65 and older was recommended, or for our population required, to get the pneumococcal polysaccharide vaccine, so the PPSV 23, so 23 different subtypes. But then in 2015, ACIP felt they needed to also include the pneumococcal conjugate vaccine, which, as you know, is given to children. So, but what this comes down to is they recommend administering 1 dose of PCV13 in addition to 1 dose of the polysaccharide vaccine at or after 65, but you can't give these 2 vaccines simultaneously. So if for applicants for the civil surgeon exam, they're required to show proof of vaccination with 1 dose of at least one of these vaccines administered at or after age 65 if they're 65 or older. So what we're saying is that if these are given before age 65, for purposes of efficacy, they don't count. And if you have somebody where both vaccines, neither vaccine have been given, the first thing you do is you would give the PCV13. So that's all you need to do as a civil surgeon. Give the conjugate vaccine. You don't have to have the person come back because they actually have to wait a whole year to get the polysaccharide vaccine. They don't have to come back for the other one. Of course, you only give the PCV if they don't have contraindications. But that's how you're starting them out, and that's the one that should be given first. And as we say here, the administration between these has to be separated by a year. And if 1 year hasn't elapsed, just mark insufficient time interval on the form and comment in remarks. Because you can get somebody in, this is the other thing to remember, is that if the polysaccharide vaccine has been given, even though it's not going to be considered efficacious if it was given at age 63, I think what they're trying to do is they're trying to have people get a single dose that's going to last them their lifetime. Now, that recommendation may change as we learn more, or as the ACIP medical experts learn more. But what they're trying to do is say, okay, you wait until you're 65, then you get these vaccines. But if you got the polysaccharide when you were 63, you can't give the polysaccharide if you see this person at age 65. So if they had received PCV13 at or after 65, and it's not yet 5 years from their, since they're polysaccharide, so they'd gotten the PCV, so you're not going to be giving that. That'd be the first one you'd give, but you don't need to do that. So then you go to the polysaccharide, and you say, well, I'll try to give that, but it hasn't been 5 years. You can't give that either. But you would just mark down insufficient time interval for the polysaccharide vaccine on Form I-693, and then remarking comments. And I know this may be something that you have to think about for a while, unless you are just very used to doing this. And if you are, I'm sorry that I'm repeating it. And if, and again, you can see that if this person had received the PCV13, say at age 63, but you're seeing them at age 69, well, actually for PCV13, you don't have to wait those 5 years. So if they had received it before age 65, you are going to have to give it to them at age 65 or later. For having to wait, or for giving the 2 vaccines? I'm sorry, who asked the question? And what's the rationale for 2 vaccines? What they're trying to do is they're trying to prevent more types of pneumococcal pneumonia. And right now what is being done is that some of those subtypes are in both of the vaccines, but there are other ones that are only in one of those vaccines. And so they're trying to give more protection. What they're going to do in 2018 is they're going to reassess, I think, and see if they really need to be doing this. I don't know if they can come up with a different formulation, but I know what they're trying to do is give more protection. And I think they probably have to gather more data before they refine this a bit more. But this is what it is for now. So this is what you're required to do. And this is just a bit of a look at the form here. So this is where we go over to blanket waivers. So not age appropriate, and you'll be marking, or you do mark that a lot. Contraindication, if there's a contraindication or precaution. Insufficient time interval. And then not flu season. And of course this only applies to flu, so it's only at the bottom of the chart that you would have an open cell to fill in. And then you can see here, you're giving the vaccine history. And we really do, and I think health departments want to see, they want to see the day of the month, not just the month and the year. You want to see the actual day that it was administered. And, this is your part here for, given by the civil surgeon. And if it is complete, you can mark that here or write down the date of the lab test if a lab test for immunity was given. Or as it says here, we still accept VH for varicella history. So now, if any of the boxes under not medically appropriate are checked, So we go back here, and so this is not medically appropriate because the age is wrong or there's a contraindication or it hasn't been long enough. And so if you mark one of these boxes for a particular vaccine or for any vaccine, it says here, may be eligible for a blanket waiver. And that's because everyone who's an applicant has to show proof that they've received all of the required vaccines and they've gotten a complete series. Now, if I were an applicant, I would always have to be marked as needing a blanket waiver because I certainly didn't get many vaccines as a child, and I'm not going to be getting them as an adult. I don't need a rotavirus vaccine. And, you know, there's other vaccines I also don't require. As you might remember, there isn't anything marked for catch-up, although you do some catch-up in adults. But it's not as much as when you're a child who's 18 or less. So there's some vaccines that just aren't appropriate for adults. But with the way the law was written, that means you don't fulfill all the requirements. So a blanket waiver is needed, and this is what you have to mark. What's good is that people don't have to apply for blanket waivers. So it's a blanket waiver in that it covers all of the vaccines, but they don't have to apply for it, and there's no fee for it. So, but if the applicant requires vaccines but refuses them and therefore can't show proof of vaccination, you have to check this last box. Applicant does not meet immunization requirements. Now, this is essentially, it's the same as saying this person is Class A. They're inadmissible because they are required to get vaccines. So if it's different if they would want to receive the vaccines, but they can't, you know, they're not going to stay and get the whole series from you because you're there just to give them the one dose. That's the blanket waiver. For this, where they say, it doesn't matter to me, I don't want any of these vaccines, then that means that they would have to request an individual waiver based on religious or moral convictions. And that would be an application that they would need to pay for. And whether or not they get that waiver, that's the one that doesn't come through CDC. That's decided by USCIS. And in my experience, and I'd be interested in what you say, sometimes people start that way, but then they realize that they're really going to need to get these vaccines. And so they go ahead and get them. And I don't know if you do go ahead on moral or religious reasons that you don't, that there are some individual waivers that are given.
The requirements are that the applicant has really to object to all vaccines. You cannot pick and choose between those. The applicant has to say that it was on account of religious beliefs or a conviction, and they have to demonstrate that the conviction or the religious belief is sincerely held. So under those circumstances, we will grant a waiver. We get a few of them every now and then.
Mm-hmm. Yeah. And so, and what Rosalind was just saying is if the person is opposed to injectable but not intranasal vaccine or not oral vaccines, then they're not meeting the requirement to be given an individual waiver. They have to be opposed to all vaccines. Okay, so this is what we were just talking about. But with the blanket waiver, you don't have to apply. Individual waivers, you need to apply, and that's looked at individually on an individual basis. As far as education goes, and I'm just about at the end here, if the vaccine series is incomplete, of course, advise them to complete the series with another provider. But you go ahead, you sign the form because you've done what you need to do. As long as everything else is taken care of, you know, the TB and other conditions. Provide a copy of the vaccination record directly to each applicant, and I know they do get the whole exam now. But this is, of course, important for school. It's important for a number of different reasons. It prevents needless revaccination and prevents people from contacting you for records that you would have to go searching for. Refugees, when they get their panel physician exam overseas, they're not required to get vaccines. The immigrants are required to get vaccines overseas. But many refugees are now receiving vaccines. This is voluntary, but the vast majority, and I mean really the vast majority, it's high in the 90s, get vaccinated. But this has been a real effort over a number of years to try to get vaccines from different pharmaceutical companies and then get them transported. Of course, they have to be transported in a controlled temperature condition, and it's taken quite a bit of effort. The ACIP schedules are used. The guidelines, they don't have technical instructions because they're not requirements. The guidelines for refugee vaccination are somewhat different from our technical instructions. For either panel physicians overseas or for what you do, they do sometimes give second doses overseas. So you may see that. But as you probably know, it's only refugees entering the U.S. with a Class A condition, with a waiver, of course, otherwise they couldn't come in, who are required to undergo a repeat immigration medical exam. So refugees just have to get the vaccinations unless they come in with a Class A. And many refugees are vaccinated by health departments who have a blanket designation as a civil surgeon, and that's just for vaccination alone for refugees only. And many of these vaccines are going to be given at the refugee examination that occurs right after people come into the U.S. But then they can come back for further vaccines. But refugees, we have a notification system set up. When refugees come in, we notify the health department near where they're going to reside, and then they have assistance of some way or another, even if it's just a notification, to come in to the health department and get more testing done, and they can be vaccinated. And there's also follow-up for TB cases who are, or I shouldn't say for TB cases, that occurs, but the vast majority of people who get followed up would have an abnormal chest X-ray overseas, but normal cultures and smears. But they're rechecked in the U.S. But usually refugees are seen just for the vaccination. The fiancé applicants, so K-visa, it's either a fiancé or a spouse of a U.S. citizen or the children of that person. It wasn't written into the law where they should get their vaccines done. So they can get them done overseas, or they can get them done by you when they come in to get their adjustment of status exam. And they must show the requirement that they received the vaccines. They must show the proof, in order to have their adjustment of status done. And these are the references for vaccinations. Again, if you're here, so this is the one for vaccination. If you go to this menu over here, you'll see the technical instructions. And so here's some frequently asked questions. You get down here for civil surgeons. Here's the mental health technical instructions, the TB technical instructions. You're on the vaccination technical instructions. Here's syphilis. I took this before the new gonorrhea technical instructions came up. But you're, just as an aside, you're no longer required to evaluate for, or I should say that chancroid, lymphogranuloma venereum, and granuloma inguinale are no longer in admissible conditions. They were just recently taken off. But there is evaluation more than doing an external genital evaluation for gonorrhea, and they're very short, new technical instructions that are up on our website now, and you'll be required to use them by August 1st. You can start doing that screening now, but you'll be required to by August 1st. So, but again, you just have to Google to get to these pages. Here's the updates down here, and then this even gets into updates. And then this is where you can find the ACIP schedules, and they do change every year. This is a great book because it puts vaccines in context. And CDC puts this out. They update it frequently. This is the most recent edition. I think you can order it from CDC. But when you have questions like, well, why this or why that, it's an excellent book. Each chapter is a different disease, so disease with vaccine, and it'll answer a lot of your questions. And then there is a separate website for vaccination guidelines for pregnant women, because it's not as simple as you don't give live vaccines. It's actually important to give influenza vaccine. It's important to, give some other vaccines during pregnancy. And again, this is our email address, cdcqap@cdc.gov. We answer the technical instruction questions, and we can't answer the Form I-693 questions unless it has to do with the medical, simply because we don't know. We can't help you. But, of course, USCIS can help you. And do you have questions? Okay.
I have a question about the proof of vaccinations.
Sure.
I have some foster families that have kids from other countries that they're taking care of. Some of them have been going to schools in the U.S., but they don't have the yellow card with their vaccination records. Now, sometimes maybe the schools will accept them, but as far as filling out the 693 form with showing that we have proof of vaccination, how do you deal with that? I also run into that problem with people that are going to college in this country from other countries. Sometimes the colleges will let them in with vaccines, and they'll say, well, we gave them an MMR, but they may not have the time when it was, the date, they'll just say it was given, and I don't have anybody's signature or whatever. How do you look upon that as far as providing proof on that form? No,
they don't have proof. It has to be written. It has to, it has to look like an official document.
Now,
so,
what about the kids going to school in a foster care type situation?
So, are they adjusting status?
Yes.
So, they're adjusting status to be
kept in this country legally. So, it's a problem because, my understanding that sometimes they go to see doctors and they are building there's a place where we can, in this country, in this state, supposedly report that we gave a vaccine, the numbers and the letters that go along with identifying what we've given, and that is kept up someplace where we supposedly have a right to go in and get that information, but my understanding is that information does not always record where the vaccines were given or what doctor or what office gave them. So I'm kind of at a loss for what to do for these kids, because I don't know if I need to go on and just give them all new vaccines based upon that when they've already supposedly received the appropriate vaccines for their age.
Well, what we say is if there isn't written proof, then you do need to revaccinate. So I would stress to them that, or stress to the parents that you need this information. And, if they can come back to your office with the information, and I'm not at all familiar with the site that you were talking about for California, but and how secure that is and who can enter the data and that sort of thing. So that'd be something that you'd have to ask, I would think, vaccination people in California. But you have to have proof. Do you know anything, Alicia, about it?
There is a California database. I think you're referring to CARE, probably, the California Immunization Record or something like that. it's supposed to be a database that it's voluntary for people to enter the vaccination records, including TB testing results. I'm not sure. It's not related to the public health department. It's at the state level, and I'm not sure who actually has access to enter it, whether it's an individual or whether it's a provider. And that's as much as I know about it. I'm sorry, but I can find out.
Yeah, I would say those questions have to be answered to see who has access to it. Yeah. So we have another one? I'm sorry, should you sign it or should you? Right. You can go ahead and sign it, because this is really, it's a it's a snapshot in time for the most part. It's what occurred when you saw this person. Now it is different if you're trying to get vaccine records or trying to get other records, but the person, if it's contraindicated at the time you saw them, they don't have to come back and see you, just like they don't have to come back and get a follow-up dose if they haven't finished a series.
My question is about DTAP. ACIP schedule says is required after 10 years, but the thing says after 7. I have so many kids in my practice. They just got their DTAP, the last one after age 4, and the pediatrician said you're okay till age 10, 11, and now they come for this form, and I say you have to have DTAP because a lot of papers got returned to our office for a 7 and older child.
Well, at age 7, you change the type of preparation to the adult preparation, and that is what ACIP says.
So ACIP, the yellow one was after 10 and 11. From 7 to 10 was purple. It was purple, it wasn't yellow.
So what you need to do is, let's see. Is look with DTAP and DTP particularly, you really have to look at the footnotes. I think the main problem I find with that is that some of the vaccines for adults, the pharmaceutical companies say they're not approved until 10 years. So then what do you do with the child who's less than 10 years of age?
If you look at the ACIP, is yellow after 10. Between 7 to 10 is purple.
Sorry.
I'm sorry for the colors.
Oops. Okay, so this should be adults.
This is adult, yeah.
So, and this is adult. So we have
TDAP is 4th from the bottom. So it starts at, is green. That's catch up.
Green is catch up.
So if they already got their regular 2 months, 4 months, 6 months DTAP, then they don't need to catch up. So
okay, what you're gonna,
after 10 or
what 10. You have to do is, it's far too complicated to talk about it here. You have to look at the footnotes and see, because it does say, you know, if you got it at a certain age, then you don't need to get more. If you finished at this age, you do need to get more. So that's why you have to look at the footnotes.
Have to explain it in the form because.
No, you don't have to explain it on the form.
So why do the papers return if we don't give DTAP?
So what you need to do is make sure you're doing it correctly. And if you're still getting forms returned, you can inform USCIS that you're getting forms returned when you shouldn't.
And my other question is about MMR. If someone comes and have one documentation for MMR years ago, be required to give the second one to be complete vaccinations, right?
Okay, so the question is, are you required to give a second dose of MMR to complete a vaccine? And you're saying if it was years ago, so are you saying this is an adult?
This is an adult.
Yeah. You're not required to do that for an adult because, you know, you're required to give a second dose if someone meets high risk, and you're not giving these for high risk, and that's often a question. You know, if I were going overseas, then I would need that, but that's a high risk indication. So you're not required to give a second dose to an adult. And the other thing to remember is that if you're giving a series, even if the first part of the series was a decade ago, it counts. So you can just complete the series. If it's indicated. In that situation, it wouldn't be. But if it's indicated.
Hello. I just had a quick question about the new gonorrhea guidelines. I know that it says that if they're over age 15, we need to do an exam and check their urine or a swab. Do we have to do an internal pelvic exam?
No.
And what about our seniors? Do we, any you know, patients above the age of 65, do we still need to check them for gonorrhea as well?
You do. And it's 15 and older, not older than 15, and it's less than 15 if you think that they are sexually active. And so you do need to do the testing routinely and continue doing the external genital exam, and that includes palpation as well as visual, but you're not required to do internal. Now, based on what the way the technical instructions are written, if you really feel that there's something going on and so you want to refer this person to a GYN, then yes, you can go ahead and do that if you think it's needed. Yeah. Yes?
Yeah, I had a question. I wonder if you could clarify on the form, the physical form, we are supposed to do a genital exam, and if the applicant doesn't want to do a breast exam or genital exam, what's the situation there? Are you supposed to tell them that that's part of the requirement?
Yeah, what you need to do is you need to look at the beginning of the technical instructions. So, and I won't be able to flip all the way to the back, but look before it gets to the specific diseases. So before it gets to TB and other conditions, and it tells you what the physical exam has to include. It does not include a breast exam. It does include an exam of the external genitalia. So basically, if somebody says they don't want that done, then you can't clear them. And we realize that this is a problem for some people. I mean, they may want to go to a same-sex civil surgeon, but it does need to be done. So it's not an option to say that the applicant doesn't want it done.
And the second question was, can you clarify about the vaccines? It seemed to me you said that we are supposed to do the first set, and then they're supposed to follow up, or if they require more vaccines. That's an optional thing for them to follow up, or I'm not quite clear about that.
No, they're not required to come back to you. They're not required to come back. You tell them what they need to do to finish the series, but no, they're only required to get one dose from you, and then you can sign off on the form if everything else is okay. Does that answer your question?
Yeah, just like, so basically you tell them that they have to follow up, and you just clear them by documenting the one set.
Yeah, you document that you gave it, and then you tell them that they do need to follow up on their own to finish the series.
Okay, thank you.
Same for gonorrhea. As a routine test, we test young women for gonorrhea as well, but sometimes we use urine test.
Right.
Is that acceptable? Or
yes.
You have to examine the genitalia area?
That you don't, you mean can you do the urine test instead of the examination?
Examine the patient and do the swab.
Yeah.
Use urine test. Can you do that?
You examine the patient.
You have to examine the patient.
Right. You still have to examine the patient.
Okay.
Yeah.
All right. Thank you.
Plus do the testing. Yeah. And remember, people who were, 65 and older are sometimes sexually active, so that's why you continue doing the testing. Anybody else?
A couple questions to you. Very often we rely on the vaccinations when they state that I had chicken pox as a child.
Right.
We try to find, I at least do this, try to find a scar. Sometimes you find, sometimes you not.
Right.
Is the statement alone enough for us to say history of varicella?
The statement alone is currently acceptable because that's the way it's written in the 2009 technical instructions. When we redo those technical instructions, it won't be acceptable.
Thank you. Second question, you talked a lot about the flu. The flu is from October 1st till April 1st. Is that correct?
Well, CDC doesn't give you an exact time. In general, that I would say that's what most accept, from October 1st through the end of March.
And the last question is this, about the new gonorrhea that is new for us. If a lady or a man, whatever, refuses to do it, you explained that then we cannot clear you. But we can send them to a same gender doctor. The conclusion of this gynecologist, for example, should come to me back?
Well, see, you really can't send them at that point to a gynecologist. You would only send them to the gynecologist if it's something beyond your capability as a physician. Not
just she doesn't want a man to be examined, or
then she shouldn't have come to you.
I understand. So if she doesn't agree to be examined, sorry, I cannot clear you.
Yeah, then she needs to go to another. I mean, do you have any comment on that, Bruce or Rosalind? On if you haven't, somebody, say a woman gets to the genital or part of the exam, or they're being told what the exam will include, and they say no, they don't want to see this particular civil surgeon because he's a man.
The thought that occurs to me is, could they have another, and this is a mixed USCIS medical issue, would they be able to have a nurse, say, on staff perform that on behalf of the male physician, and because it's a staff person, he could accept that result?
Yeah, see, and this has come up, of course, overseas, too, and we've actually said no, that it needs to be the person, you know, who has, overseas is the person whose signature is on the agreement, and here I would think it's the person it's the doctor.
If that's how you view it, then that would have to be the answer. So, and this is not eligible for referrals, so.
Right. I mean, if there was something complicated and you felt they needed to be referred, then you would refer them. I mean, that's the same with any condition, but this is just your basic.
So we would tell over the telephone when they apply for application that the doctor will examine, he's a man, and if you have any objection, you have to look for a female doctor.
Exactly. Exactly. That's it.
Yeah. Thank you.
Yeah. Thank you. Yeah. So, and I think there was just a couple things that people had asked me this morning I thought would be good to mention. One is someone said, what if you see a malignancy on a chest x-ray? What do you do about that? And so what you do, if you see something and you think that it's a malignancy, what you would mark that as a B other condition. A malignancy is not inadmissible to the United States. It could be in other countries, but not to the U.S. But of course, what you're most concerned about is getting that person to somebody who can treat them. So you need to tell the applicant that's what you think is going on, and the sort of workup or follow-up or referral that they need. You need to just be very clear with them. This is what it looks like. This is what you need to have happen. Now, you can still sign the I-693, but, you know, having, you know, have marked down there that it's a B other, and you can mark in the remarks what exactly is going on. But you want to do a service to the patient. The other thing that someone brought up was what if the radiologist, in looking at a chest x-ray for TB, what if they say, well, there's a pneumonia? Remember that a pneumonia can be TB. So if that's what you're getting back, or if the radiologist is saying it's an infiltrate, that person needs to go to the health department unless they're acutely ill, and you actually shouldn't examine them if they're acutely ill. But if they're acutely ill, then, you know, it may not be TB, it may be something else, or it may be very bad TB, and you'd have to make that clinical judgment. But it's always important that the radiologist knows what you're looking for and that they answer the question, and this is something that Dr. Chang brought up. And remember, if it's an infiltrate, it can be TB. Certainly if it's lymphadenopathy, it can be TB. If it's an effusion, it can be TB. If it's nodules, it can be TB. If it's a single line on a chest x-ray, it can be TB. So you need to make those referrals to the health department. And, you know, radiologists, unfortunately, in the U.S. aren't as used to reading for TB as radiologists overseas in many countries. So you have to keep your suspicion up.
Okay, I have one more question, if it's possible. So that for drug screening, and whoever says that using marijuana, medical marijuana, what we should do at this point?
If the applicant says they use marijuana. So you've probably noticed that the technical instructions changed on that. And so what needs to be done is to see if they actually meet the definition in the DSM-5 of whether there's, and I don't always get the words right, but basically whether there's abuse or addiction. You know, in 10 years ago it was if there's more than a single use of marijuana, that made them a Class A for drug, and that's not true anymore. So if you don't have a psychiatrist to refer to or psychologist or somebody in mental health, it doesn't have to be an MD, then I would get that person, because that would be something for most, and I don't know if this is true for you, I shouldn't jump to that conclusion, but I think for most medical people, we're not good at being able to make a conclusion based on what's in a psychiatric manual. So it would need a referral, because if that person doesn't have evidence of abuse or addiction, and now they're called substance-induced disorders, and there's a few other names, then they wouldn't be Class A. Yeah, it's more complicated, but it's probably a better system than we used to have. And I think I'm probably out of time. People are converging.